Good afternoon, everybody, and welcome to this July session of the CareNext Collective. My name is Danina Kaptanovic. I'm the Vice President of Innovation at WRHN and Chief Health Innovation Officer at the University of Waterloo. I want to begin by thanking each of you for showing up to this conversation. These aren't easy stories to tell, but they are the ones that move us forward. Today, we are revisiting WRHN's first real attempt to co-develop and adopt an AI-enabled clinical tool. This project didn't scale, but it didn't fail either, not in the ways that matters the most. We've gained from that experience, reshaped how we think about readiness, governance, partnership, and the very nature of innovation in complex environments. And what we built since, our structured AI readiness work, our new governance frameworks, and the leadership many of you are contributing to has its roots in this story. It's fitting then that we're having this conversation just days after Signal One, our partner, released their white paper on the complexity curve when it comes to AI adoption. That paper described the tipping point many health systems face, an explosion of AI pilots without the connective tissue. No data infrastructure, no evaluation scaffolding, no capacity for strategic alignment. And I think that's where we were. We weren't yet equipped to integrate. And that's what today is all about. Not critiquing the past, but understanding how these inflection points shape us. So in the next hour, we'll hear directly from people who were part of that initial journey, from clinical leadership and operational leads to our industry partner. We'll talk about what it felt like, what we've learned, and how we're doing things differently today. This is exactly what the CareNext Collective is for. Real conversations about how innovation actually happens inside health systems. And I want to thank Manulife Canada for sponsoring this work and for believing in the importance of reflection as much as action. So let's begin. I am thrilled to be joined today by a group of colleagues who bring deep insight into this journey, each from a different vantage point. First, we have Dr. Payal Agarwal, our Chief Medical Information and Innovation Officer at WRHN. Payal has been instrumental in shaping how we think about digital strategy and AI governance across the organization. Carla Girolametto, our Director of Research Operations, who brings the lens of evaluation and systems learning. Carla has helped ground our innovation work in thoughtful evidence and infrastructure. From clinical operations, we're joined by Elliot McMillan, Program Director for Medicine at WRHN, and Jenna Merritt, Clinical Manager, both of whom were on the front lines of this initiative and bring powerful perspectives on implementation and adoption. And finally, last but not least, we're very glad to welcome Sheena Mawani, Senior Deployment Manager from Signal One, our co-development partner. Sheena brings the industry partner view, what it's like to co-develop with a health system and how those partnerships evolve in real-world settings. So thank you all for being here and for your openness in helping us learn together. To start us off, I've invited two people who were closely involved in initiating, shaping, and supporting this work to help ground this in the context. So Carla and Dr. Agarwal, can you please very briefly walk us through what this project was all about, why we pursued it, and what it set out to do, and how it unfolded on the ground. So Carla and Payal, over to you.
Sure, I can start briefly and then pass it on to Payal. So thank you so much, Danina, for inviting us to this innovation collective. We began the partnership between WRHN at Midtown, formerly Grand River Hospital, and Signal One in 2022. We were early in our innovation journey, and I'll talk a little bit more about that later, but we had heard about this, the product, the solution of Signal One. And really, we wanted to bring it to Grand River at that time, WRHN now, for the purpose of really enhancing patient care by supporting clinician decision-making by implementing this AI-powered clinical decision support system. So really, it's It's the system that it's meant to support clinicians, nurses in making certain decisions for the benefit of our patients. It's a predictive tool, like many of the AI solutions are. It was drawing from a number of various clinical data fields, both historical and existing data fields from patients to predict changes in medical conditions. We pivoted what had been done from Signal One before, where it was predicting mortality. We were looking at are patients likely to improve and ready for discharge within the next 48 hours. Of course, we were still looking at those patients at risk of deterioration. And really, the aim of the project was to look at enable earlier interventions for discharging, improve potential discharge planning, also optimizing some resource allocation. There was the idea that we could allocate some of the patients with more acuity to more experienced nurses. We were going to really look at that support for the clinician expertise and help manage some of the hospital capacity pressures, particularly from the flow of the patients from the ward, from merge into the ward and then back into the community. And maybe I'll leave it to Payal to continue from there.
Yeah. Just briefly, thanks, Carla. That was a great introduction. So yeah, I think as many people know, we're situated in one of the fastest growing communities in Ontario, if not Canada. And, like many hospitals, we had incredible blood pressure at that time. So I think there was a strong desire to really look at how we can help, with delivering high quality care, but making sure we sort of are able to flow patients through our hospital kind of safely and appropriately, and how we can support. So that was really, I think, the impetus for why we picked that use case with Signal One, and really did focus on our sort of hospitalist and general medicine units as some of the first places to start. Excitingly, we did have really great, we'll talk more about this, but we did have, really strong excitement from our leadership, both on the sort of digital and clinical sides, and a great partner in Signal One. So, we definitely, back in 2022, seems like a long time now, came together to do this sort of exciting work. And I don't think Carla mentioned, but it was under also a CanHealth sort of framework that we participated.
Thank you. Thank you both for that introduction and for situating us around the project. So let me start off with Carla. Thinking back to the early stages of innovation at, now REN and what was then Grand River Hospital, what were some of the initial questions you had about this project, Carla? And were we in a position to answer them?
Let me check that I'm unmuted. Okay, so I'll say when we look back to the early days of innovation at REN, it's important to remember the context of when we started working on this project. We were just emerging from the pandemic, and it was a time that had reshaped how we were thinking about health system resilience, data, and technology. Innovation was still new to us in that formal sense of innovation. And our primary focus at the time was really our partnership with the CanHealth Network, and Payal alluded to that. They played a pivotal role in supporting and funding the ability to try these emerging solutions like the Signal One platform and engage in this type of projects for a hospital that, as a community teaching hospital, wasn't used to thinking these terms. So some of the early questions that we asked ourselves really were, can we meaningfully apply AI in our operational environment? Will this solution add value to our clinical teams? And I think perhaps more fundamentally, we ask, can we build the internal muscles needed to try something this new, this early in our innovation journey? Because really we were very early. We didn't obviously have all the answers, but we had something that was just as valuable, which was the commitment to learn and to innovate. And we really leaned into the idea that innovation wasn't about certainty, but it was about discovery. So we chose a new path for, I would say, our region here in our hospital, which was not to held back by risk aversion, and instead adopted what was one of our values at that time in our strategic plan that still shapes us today, was courage to start and hard to finish. And we did have that courage. So those were really the initial questions that we were asking ourselves when we embarked into this project. If that answered the question.
It did indeed. Thank you for that, Carla. An important part of running innovation projects and AI is not sort of exempt of this, is evaluating tools in real world settings. So from your perspective, can you speak a little bit to how do we get better at evaluating AI tools in real world settings, kind of beyond academic rigor? How do we ensure operational relevance?
Yeah, I mean, academic rigor is incredibly important, but it's only one side of the coin. And when we partner with these companies that create AI predictive algorithms or utilize artificial intelligence to enhance some of the solutions, I think the academic rigor is there most of the times from the design and partnering with the right people that want to use AI for good. But to truly evaluate AI in the real world, particularly in healthcare, I think we need to shift our lens to include operational relevance, clinical usability, and human factors. The human factors particularly being incredibly important, as we've learned from this project. I think first and foremost, we need to involve frontline teams early and often, not just in the implementation, but in the problem definition. If artificial intelligence is solving a problem that no one feels, it just won't stick. It just won't be used. And tools have to be designed with the people who will use them and not just for them. Second, I think we need to look beyond metrics like accuracy and precision. Those are important, and that is the academic rigor that is done most of the time already ahead of time. But we really need to be asking ourselves, does it improve the workflow? Does it reduce cognitive burden? Does it support decision-making in a way that feels natural and trustworthy to the actual users, to the clinicians, to the nurses? And these human factors are critical, in my opinion, and sometimes too often overlooked in the evaluation frameworks. And finally, I would say that real-world evaluation means being comfortable with the iteration. AI is definitely not a static tool. It evolves. It's just the nature of exactly how AI is. And our approach to assessing it should evolve as well as the solution evolves. So we need agile, cross-functional teams, clinical operation, digital research as well, working together to continuously monitor, adapt, and co-develop the solution. So I think that ultimately, if I think about this, we get better by embracing the real world complexity, not just by avoiding it. AI is definitely not a plug and play, it's very contextual, and the success depends as much on people and processes as it does on coding and the data that's behind it.
Thank you. Thank you. This definitely speak my language on this one. So this next question is both for Carla and Sheena, and I just want to say that, to all our panelists, please, if you feel free to add anything to any of the answers that your fellow panelists offer. So question for Carla and Sheena. Looking back, was this an experiment that failed, the dreaded F word, or a success in organizational learning, which is frankly how I like to frame the notion of failure. But over to you. Was this an experiment that failed or a success in organizational learning? Maybe Carla first and then she.
Carla, okay. I'll say that I like a particular quote from a previous Nobel Prize winner who said, if you learn something from it, it's not a failure. And did we ever learn so much from this project? It was truly foundational for us. If I go back to the context that I was talking about before, being one of our early framed innovation projects, having the ability to do it through the Can Health, so funded and through the rigor of picking particular KPIs, it definitely was foundational. It helped us to better understand a lot of the mechanisms of AI adoptions, internal alignment, and the sheer complexity of translating algorithms into practice, into everyday practice. And I find that, even speaking here today, I have a lot more confidence speaking about AI and implementation of AI in healthcare because we went through this exercise. It really built the groundwork for how we're now thinking of AI at REN, how we're going to be, developing the full massive world of AI at REN with governance, data, ethics. So in my opinion, definitely we learned something from it. So absolutely not a failure.
I see Payal agreeing vigorously. Before I give it to Sheena, Payal, would you like to say anything?
Absolutely. No, I think Carla highlighted it so well, but I think, it's really allowed us to understand foundationally what we need as an organization to really sort of reach our ambitions around AI. And, another concrete example is even our data infrastructure, right? So now as we start to move forward and make investments, there's so much learning that we have around what worked and what didn't work, where the challenges and barriers were. And that's all going to go into, sort of informing our investments moving forward on data infrastructure. So that's invaluable. I mean, that is the reality of this type of work. AI is new for everyone. It's difficult. No one knows the right answers from the get-go. So you have to, there is a point you have to try and learn. And I think, it was a good step for the organization to take that risk and now kind of build on those learnings.
Thank you for that. Sheena, from your perspective.
So back in 2022, this was also Signal One's first AI implementation in a hospital. And so there were definitely learnings for us coming out of this implementation as well. It was also the first time that we were implementing our flow solution because, as Carla mentioned, we had made a pivot from our deterioration solution to this flow solution based on what the hospital expressed as kind of the burning platform or the problems associated with flow. I think that one of the things that we learned that we now do moving forwards is we now really properly test whether the problem that's articulated by the hospital is a problem that actually exists. And I think likely the problem exists, but it's usually more complicated than what is expressed kind of at the administrative level. And so for us moving forward, so I think it was a failure for us to test that problem, but I think what is successful for us moving forward is with each additional hospital we've gone to, a large part of our implementation time is spent on validating problems up front so that we can make sure that it's worth the investment.
Thank you for that, Gina. And I can say from my vantage point, although this project predates my tenure, it is one of the ones I dove deep in on my arrival as I was handed the responsibility for organizational AI strategy, and it's led to the readiness assessment work that we are doing right now that will sort of, give us a sense across the organization and across our capabilities, where do we stand, and allow us to also paint a vision for ourselves in terms of how we want to leverage AI. So even the sort of I would say as a person who came in after the sort of the learnings of this project continued and endure and are shaping how we are approaching AI as an organization. I'd like to ask Elliot, our medicine program director at REN right now. Elliot, from your perspective, what problem were we trying to solve with this tool, and why did it matter to the medicine program? We heard a little bit about this in the beginning, but if you could maybe give us a bit more of a deep dive.
Yeah, for sure. So, I mean, we're trying to solve a couple problematic areas. Say problematic areas intentionally because, like we mentioned, we didn't really refine the problem necessarily as well as we probably could have to begin with. But we're really trying to work on estimating the patient's date of medical stability and how that and their readiness for discharge after that. So although the discharge planning starts when the patient's admitted to the hospital program, there's a lot of execution of that program or that planning at the point when the patient is medically stable and ready to go home or wherever they are supposed to go after that. So the concept was that if we could predict when this patient or a patient was ready to be discharged based on medical stability, we could better align the discharge planning resources to proactively prepare for that date and reduce the amount of time between being medically stable and being discharged. And in so doing, over a number of different patients, save some length of time or length of stay and open up some beds and get greater capacity within the programs. Because so that's kind of the main area that we were looking at, or the main kind of problem area that we were looking at with this particular solution.
Thank you, Elliot. What were the biggest barriers to clinical adoption? Were they technical, cultural, structural, or a bit of all of these?
Yeah, I'd say a little bit of all three of those. Like the technical barriers. I mean, the AI tool itself, was developed by single one, was great. I mean, it produced the output that we were hoping for it to be produced. We were able to get the infrastructure behind it in order to feed it the information it was needed. We were able to get that output in a sort and in the part of the electronic medical record where clinicians were able to see it and use it. So there's a lot of good work there that's at first we kind of thought might be a little bit, maybe some problems, but at the end of the day, we were able to figure that stuff out. However, technically, I think one of the bigger challenges was just the validation of the output. Medical stability, readiness for discharge are pretty complicated. And there's really no gold standard to train the output on from at this point in time anyways. So that was a little bit tricky. And for example, I mean, we have patients that may have renal disease or they're battling cancer, and their blood work may look absolutely terrifying, but that's not necessarily unstable for them. So when the AI tool is able to look into that patient, the tool would come out and say, yeah, the patient's not ready for discharge, but in reality, they could have been. And conversely, there may be somebody that is medically stable based on the data that was available, but they're just so far deconditioned that we couldn't send them home safely. But things like that may not necessarily be appreciated by the tool as it was at that time. So technically, there's a couple little things, I think, well, not necessarily little things, but complex things that we just weren't able to overcome at the time. Culturally, yeah, there's definitely some challenges there. I mean, with previously mentioned technical issues, it was very easy for an already skeptical group to find error and criticize the tool and not want to move past that point and actually trust the outputs. So culturally, that can be quite challenging, and of course will diminish the buy-in to the tool. And I mean, clinicians, nurses, doctors, PTs, OTs, etc. I mean, they're all trained to see deviations from the norm. They're all trained to find problems and scrutinize these problems, and then apply very high quality evidence that's been created in a very empiric way to fix those problems, which can make innovation a little bit challenging because it's a little bit more risky. For sure. So there's definitely some cultural barriers there that I think over time, as we engage in more of these projects, we'll start finding ways to make improvements on. And then structurally, there's a couple little pieces. So like the human factors component we were talking about, and one of the pieces there is just how we fit this tool and the output itself into the workflow of the staff in a way that there's meaning for them, and it adds to their clinical decision making. And then in so doing, there's value for them to have. Those are, yeah. So I mean, really, there's a little bit of barriers in all three areas there, but certainly things that over time we can address.
Pal, can I call on you? I mean, you're as a physician, and
Yeah,
you and I
absolutely.
have had a privilege of having these discussions with you, but if you could share some of your
Yeah,
insights.
absolutely. No, I mean, I think, look, AI is new, but it's also, there's a lot of principles that we've known forever, right, with digital. And I think the human factors piece is so big, right? You need to understand how these tools integrate into the day-to-day workflow of our clinicians, of our frontline, and kind of to Sheena's earlier point, what problem are they actually trying to solve? And what you have to have we talked about theory of change, or some idea about how this prediction, which at the end of the day is a number on the screen, actually links through people and process to a better outcome for our patients. And I think as people have alluded to, more work up front with our frontline clinicians, not just sort of our senior leadership, to really understand that kind of link and the theory of change would have served us a lot. We started to do more of that, but there's a lot of investment in the technology and the data and the integration before we worked through that, whereas, ideally the order would have been flipped. The only other thing, I think the other thing to remember, again, we do have groups in our hospital, like practice, that are used to helping clinicians, nurses, physicians understand how to integrate new data points into their workflow. So I think we probably, making sure to really leverage those resources. You may have to upskill them a little bit on AI, but, using data to drive clinical practice is not new completely. So we do have, I think some foundation in the hospital that we can build on in future projects.
Thank you for that, Payal. So you alluded, as Elliot alluded earlier, Elliot, what kind of support or change management would have made a bigger difference?
Yeah, I think bringing in the clinical teams right off the bat to help define that problem, add some perspective and introduce how they would need the problem solved in a way that's meaningful for them. I think if we were able to do that right off the beginning, we would definitely get a little bit more awareness of the solutions that could be offered, and the opportunities that we can kind of capitalize on, but also a little bit more trust and I guess desire to change and motivate or motivated staff to make those changes and support the changes that were in front of them.
Thank you, Elliot. Sheena?
And co-design is a really excellent strategy for change management. And so we try to adopt that with the hospitals that we work with. I think in this project, we didn't have enough clinical engagement. Like we couldn't even identify physician champions from the hospitalist side to be on this project. And so co-designing a solution without the people that are going to be using it is going to create a lot of barriers to adoption down the line.
Thank you for that. Jenna, over to you. Can you walk us through what it was like on the ground? How did the intervention land with your team?
Yeah, thanks, Danina. I want to start by saying our frontline teams are exceptional. The medicine program is full of dedicated, intelligent, and hardworking individuals who care about each other and the patients they serve. So I was really fortunate to be a part of the early meetings with senior leadership and Signal One and have this brought forward to us, and thought it was a real exciting time for the medicine program and a real focus on a program that is usually hard to pin down or explain to people because we have complex patients with multiple needs, and it's really hard to really get a focus on medicine often. So it also really helped me being early on in the conversations to really understand what the intention was, both from senior leadership and from Signal One, and be a part of that collaborative AI solution and bring that to our teams. So I could bring it forward with a real authenticity with my team and encourage and facilitate the early adoption of this tool. And I really want to echo Carla's earlier comments that our medicine program really did have the courage to start and the heart to finish. We hear AI a lot more now. I think it's a lot more into our lives, but a couple of years ago, it was not. And Elliot also said earlier, skepticism is a big thing, I think, with people in healthcare, and we need to, and with our teams. So, but our teams really took this on, and the introduction of the tool was actually easy. It was easy to access and read, and we got it. But the real challenges was in what to do with the information. Yes, we had a list with predictions, but how do we use this to help staff's workload? Or more importantly, how does this improve patient care? And we really found through this to achieve that required changes to staffing models, to workload prioritization matrices, and changes to our models of care and how we've been going about things. So in keeping with our patients and staff at the forefront of our minds, we regularly had to ask ourselves, is this tool working for us? And I think we kind of underestimated how much work like that integration really was in it. But if I also continue, just that I believe our teams really did put in their full effort into using this tool, providing feedback for its improvement, and trying to find its usefulness. It was because of that effort that, to me, this was not a failure of our teams. This was just not a solution that fit our team's workflow at that moment.
And I think you bring out sort of the crucial point when I talk to founders and companies oftentimes who are baffled as why technology is not making it into healthcare. And I think you're sort of alluding to one important aspects of that, which is that oftentimes it's a tech first approach and not a problem first approach. And so just by sort of flipping it around and engaging with willing partners, such as Signal One, we can in fact not only support and help the creation of technologies that make a difference, but manage that change by involving people into the process of co-design. Sheena, Jenna, before we continue, I just want to invite our audience, our listeners, as you listen, I invite you to think not just about what went wrong, but what we now understand better as most of our panelists have spoken to so far. What lessons do you see here for your own teams, your own programs, and what kind of supports would it make it easier for you to partner with AI in your own work? And I invite you to post your questions and comments in Slido, which we will be getting to in 10 or 15 minutes or so. Jenna, were there moments where you realized something wasn't clicking, and what did you do? I mean, you mentioned this a little bit in your earlier intervention, but if you can call it out specifically.
Yeah. Things. Yeah. So I think the initial excitement and opportunities in using a tool were there, and we could use those things. But it really was in those questions of asking, well, what do I do with it? What can we do with it? Okay, we can predict someone's discharge, or they might be ready. So we try and start to have some conversations. But maybe due to other workload and assessing patients or doing all of those things, we don't have the time to do it. So then we have a very high functioning, very well educated staff as well. So then what we started to see was, if we're not able to do that, or we have to shift things, what are we giving up? If I need to focus on, these predictions and getting people ready, am I losing out on the back end of getting people who aren't at the top of that priority? So it then became these kind of dilemmas and these conversations about, where do we only have so much time, manpower, and that. So as those questions came up, it was really looking at focus. It was working through things, but I really do want to stress that the teams, while they would ask questions or what the value is, they were then engaged with, I had the great opportunity, Sheena and some of the other people with Signal One would come and engage with them and ask them. And for them, I think it was really positive as well, in that they were being heard. Something was going to be tried as well, or some adaptations there. But it just really became little things kind of eating away at it. If I can't use it, why am I spending my time on it? I could use it somewhere else. So.
This question is both for you and Sheena. Jenna, what does readiness mean to you at the unit level? And what do teams need in place before something like this can take off?
Yeah, I look at readiness, and one of the definitions of it is a willingness to do something. And I have to say, my team, this program, and here at RHN, we show readiness every day. Every day in what they do, they are ready to do something. They have a willingness to try something, to do something. So I believe as well that staff have to have trust in their leadership, and believe with what we bring them. And with that comes readiness. They need the access to necessary resources. And what we really need to do is know the why, just as we do or anyone else. They need to know, why are we doing this, and the impact on themselves and their patients, or what's going to bring them along. And as I think Sheena said earlier, and I'll echo, be a part of, or sorry, it may have been Pale, be a part of the development and implementation. So if they're a part of that, they understand it, they can have that excitement and grow with that as well. And then confidently, I can say they're ready. They're ready to change, grow, and adapt.
Thank you for that. Sheena, I'm interested in your perspective on this.
I think just like connecting to Jenna's point about the why. So like, what is the problem to be solved? Like, I think that needs to be very clearly articulated, and then it needs to resonate with the frontline staff. Because I think like there's two levels. It's problems that administration sees, and then what are the problems that are actually on the ground? And sometimes they're not aligned. And if it's like a problem that the administration sees, then the clinical team needs to trust and be engaged in the process of trying to solve it. But if they're not like personally connected to it, I don't think that there's as much. I think that they're like, they might not spend as much time or effort that is required through iteration to actually solve the problem. And I'm not saying that Grand River didn't solve the problem. Like, we put a lot of work into that. And I think also workflows related to discharge are probably some of the most complicated ones in the hospital that touch the most number of people, where the actions are very different depending on the patient. Like, these workflows are very diffuse. And so there is going to be a lot of effort that's required to solve this problem. You can't just do it, I think, over a period of even like 6 months to 1 year. Like, there's a lot of investment that's needed. So yeah, the two things I would say is like, let's validate that there's a problem to be solved. That's like important for readiness. And then also let's make sure that the capacity is available for the clinical staff to engage in the problem solving process, because it's going to take time, especially related to this problem.
I think what you say also speaks to the importance of having a sort of broad organization-wide culture of innovation, where people are primed and there's reserved time in their day-to-day to spend on activities like this. Payal, how did this experience shape REN's current thinking around AI governance and readiness?
Yeah, absolutely. I think as we've said before, it's been foundational, right? Like, first and foremost, it's given us the confidence, to move forward and say, look, we've had our first try. There's lots of learnings, and we really are going to, continue to move forward in an ambitious way around AI as an organization. So I think first and foremost, that's huge. It's brought together, I think, a lot of the right people around the table. So, digital, data, clinical, innovation, all of these great groups coming together to really say, okay, how do we do this collectively together, right? This is, it's not something that any one group can figure out on their own. You really need all the parts of the hospital coming together. And, I think that's a journey that we're on right now. So a lot of that comes from our learnings. I think the governance is critical. Like, there's so much learnings here that we have to sort of operationalize and make sure, are operationalized the next time around, right? As learning is failure is great if you learn and you operationalize those learnings next time around. Just to pick up on a few things that were said, yeah, I think, making sure that you have that space and capacity for clinical co-design early on. And it takes time. It's not something people can do off the side of their desk. So how do you find, in all of our incredible busy lives, how do you find the capacity for our front lines to help us do this? From a digital and data perspective, how do we make sure our infrastructure is ready? So all of these great questions that, and barriers that we experienced with the project, even though we managed to kind of work through them, we're proactively looking at how we can, make it go smoother the next time around. And I think that's, that's a great journey to be on.
And from your perspective, what were some early signals that you saw that the project wasn't sustainable, and how did you interpret them?
Absolutely. I mean, so I came on maybe not quite at the beginning. When I joined the organization, we were a couple months into the project. I think what's been talked about already is that idea. It did feel like a bit of a technology first approach within our organization. And sometimes, the technology work, I mean, there is so much there, but around moving our data, getting the data pipelines, all of that, there was a lot of work and effort being put there, which is amazing. But I think, I didn't see the same, or probably it should have been earlier, as we talked about, about effort initially on really digging deep into the problem and theory of change and working with our frontline and human factors. So that's always, sometimes it still works out, but that's always a bit of a concern when you see it on a project. I will say we did, once we sort of got the prediction working, it was clear that the first time around, wasn't working for our clinicians. But as Jenna talked about, we did great work coming together, iterating. We tried putting the prediction in emails, putting the prediction in the EMR, different places on our EMR. So we, once we sort of got to the, realized the first version wasn't working, we really did come together well with the front line to try different versions. But I think even once trying that, it was that idea, I think it didn't take long using sort of co-design iterative approaches to realize that this is much bigger. This is about, a much bigger kind of process, organizational approach to discharge, which is complex and, was probably out of scope of the project. So, I think there was different points along the way, but always when you sort of don't see that really clear kind of problem definition up front, that always gives you a moment to think, we might be missing something here.
If you could redesign this effort from where you sit now, what would you do differently, Pam?
Yeah, there's so much that went well. Again, we had a great digital partner. We had strong leadership buy-in. So I think all of that, so much like motivation to do this and try. And so I think that was all amazing. So I would maintain all the stuff that worked as a first step. I think, what we've talked about, I would have brought in our clinical frontline, physicians, nurses, allied health, everyone earlier on with, time to think about this difficult problem and work together to co-design, understand the problem and sort of co-design the solution. And that means not just the prediction and, where the prediction is going to sit, but how does that prediction through people and process, as I said, link to the final outcome. And I think, taking the time to work through that before we really, went deep into investing in technology. And I think that would have been, if I have one thing, would have, I think, been big for this project, would have really helped.
Sheena, from Signal One's point of view, what was the promise of this project, and what did Signal One drew to this use case?
Well, it was
Signal One to the use case, sorry.
It was the hospital, actually, it was Grand River Hospital that looked at what we had, which was a deterioration solution, and said, well, actually, our problems are more around flow, and can you help us figure out who is going to be stable? And as we spoke to other hospitals, like the same problem kept coming up, which, looking back, I'm not surprised because we have a capacity problem. And so flow is going to be a problem. And so naturally, we wanted to help the hospital. And so that's why we decided, let's give this use case a shot, especially because we hear it's a problem all over the place. I think when we initially also started the project, there was this hope that we would have a really good data point in the data to predict medical stability. We knew that part of the workflows at the hospital was that physicians would actually mark in the chart when a patient became medically stable, ready for discharge. There's an MSRD order. But when we went in and looked at that data to use that for training the model, only 10% of patients had that data point. And so then we had to reevaluate what our approach was going to be to train the model. But initially, we were excited to hear that there was this data point related to medical stability. So I think that, also got us excited about this use case. Yeah.
How did the deployment experience at then Grand River Hospital, now REN, compared to your expectations?
I think it's interesting from my perspective. I worked at hospitals for almost 10 years before I moved to Signal One. And a lot of a lot of culture change that I was trying to bring to Signal One is that we need to care more about workflows than technology, because actually that's the harder part. But starting this project, there was just tons of excitement about the technology, and there was a lot of focus both from the hospital and from the company on, is it even feasible to run AI in production? Because for the most part, a lot of these AI algorithms were published research papers that were looking at historical data and seeing how accurately it could make a prediction. But when we moved it, or you try and move something into production, there's a lot, or into real time, work with patients, there's a lot of nuances that come. is the data that's available historically actually available in real time, such as like diagnosis. In Ontario, diagnosis gets applied, weeks, months after. And so that's not a data point that's available in real time for the model. And so I think that there was a lot of focus on, can we actually get this to run in production? And so I think less focus on workflow and kind of like, what are the discrete actions that are going to happen after we receive this prediction? I think eventually we got there because we saw after we implemented, like nobody can do anything with a data point unless there are kind of more discrete actions. And then as we discuss the discrete actions, it's like, well, people have limited time. So how can they actually take these actions when they have all these other things that they have to prioritize? So I think my personal expectations was that there was going to be more work, like focus on workflow up front. But that didn't come, I guess, till later on in the project after we kind of all moved past that technology piece.
Lastly, really important question from my perspective. What does good partnership look like in AI co-development to you? And what advice would you give us and other health systems from your experience here?
I think this is a great question, also because I'm an AI fellow with AMS, and actually I made this my topic for research because I was on the hospital side and then I moved to the vendor side. Like I have like very strong memories of like making that transition right when I started this project, and sometimes feeling like an outsider to the hospital after being like very embedded within a hospital and being able to like have very open conversation, be able to like observe workflows. And I did go to Grand River and they did let me observe, but just to like continuously observe workflows, have lots of conversations with frontline staff. Because from my perspective, the frontline staff know their problems. And what the vendor knows is what solution they can create. And if they've implemented the technology before, they also probably have an idea of what workflows might be successful just based on previous experience. But the hospital has to tell you what aspects of those workflows can actually is compatible with their environment. And so my advice that I give other health systems is to be a little bit more open with your vendor and to really look at it as a co-design and to like embrace them as a part of the team and not as a vendor that's trying to sell you a product, because that's not where I was coming from. And to just really make them a part of your team so that together you can figure out what the best solution is.
Well, I've certainly, at least in part, made a career and a bread and butter in creating structures that actually function in between, right? Like sometimes I find that the horizons are so very different that you need a facilitator in that relationship, someone who sort of understands the reality of both and can kind of ensure that you're speaking the same language and the right things are communicated, and that's exactly the capacity that we are building into our CareNext team that will hopefully help these relationships work better.
And the second thing I would say is like to also for the hospital to invest in capacity building so that especially around AI in particular, these predictions were probabilistic in nature, meaning like it's not black or white, they may be wrong. And I don't think clinicians like to operate off of like probabilistic, things in nature. And so I think that there's also just more education that needs to happen just to like the average human out there in the world as to what these predictions actually mean. And then that can actually help inform how people can brainstorm what they can do with them.
Thank you. Thank you for that, Gina. So with this, I'd like to open it up, use these last 10 minutes or so to get some questions from our audience. So Dana and Courtney, if you wouldn't mind sharing our Slido screen so we can take some questions from the audience. All right. So first question. What strategies will your team use to engage clinicians and address cultural or buy-in barriers to prevent wasted time and resources from premature or overly accelerated implementation? Should future innovation be more clinician-driven? I feel like we've touched upon this a lot, but certainly if Elliot or Jenna or Payal, if you'd like to maybe start us off on this one.
I can start. Yeah, I think this
Mhm.
is a great question and is such a foundation of, how we need to move forward. So a couple of pieces. Yeah. So making sure that, we're not wasted time or resources on premature implementation. So that goes a lot to what Sheena said about, building up our capacity, our expertise as an organization, right? The more we build that up, the better we're able to really understand which solutions, which companies, which partners are worth investing in. So I think that's a big piece of it. I think as we've talked about over and over again, future approaches really need to bring in those frontline clinicians from the outset to really understand the problem. And again, not expect them to do it off the side of their desk, realize it's important. It's, it takes time to do this well. And, as an organization, finding ways to give our clinicians and our frontline, amongst everything else they do, the time and space to do this well. And I think that co-design approach means that they are clinically driven. Absolutely. At the end of the day, technology for technology's sake really has no value. They have to, help our clinicians and ultimately, drive outcomes for our patients. So I think, as part of that governance model, being really clear on the need for those steps will be, is so critical moving forward.
For me, the answer to this is absolutely yes, right? It has to be clinician driven. As I've said earlier, half the problem is that we oftentimes start with the solution and then look for a problem to solve. And if we flip that around and ensure that and clinicians, and I would also say patients are at the table, we're definitely in better position to create solutions that matter and make a difference. I don't know, Elliot or Jenna, do you have anything to add to this perspective? Elliot?
Yeah, I mean, I gotta maybe add one piece here, just in terms of engaging clinicians and addressing the cultural aspects of starting something like this. I mean, we need to put in place cultural components that allow for vulnerability and for people to be okay with, failing within the context of innovation and experimentation within this environment. So, I mean, we don't do that. That's not part of our role. That's something that we're very uncomfortable with and something that we strive never to actually do. So just enabling that kind of mindset within the frontline staff, the clinicians, and not only just enabling that mindset, but putting in structures to actually allow them to follow through with that process or those processes at the beginning of these ventures would be very helpful.
And I'll add to that, Elliot, sharing, which is exactly what we're doing here and why is it so important, right? Like they're not easy conversations to have, but they're crucial conversations in advancing innovation and building that culture of courage, right? To try. Can the panel please reflect on barriers and enablers to involving frontline staff in co-design from very, very early in process like this? And if there are any parallels that can be drawn to co-designing with patients or community members. So, I mean, I think pretty much anyone can take this one.
Denise, I'm happy to answer kind of just from my perspective. And I just want to start and echo something Carla briefly touched on. At the point of this, when this came on, were we coming out of the pandemic or still in it, where our frontline teams and all of us were exhausted? There was not much capacity in anyone to do anything outside of coming to work, doing my job, looking after my patients, getting through the day and leaving. So, in an already exhausted workforce or burned out workforce, it was really hard to then engage with them and say, can we also get you to think a little bit outside, try something a little bit new, when they were in this constant change of a pandemic with things changing and kind of being at this height. So I think it would be different now a few years out. There are some people who now have that capacity with new staff, new faces, and that coming through. The other part of it too, and really in a challenge with frontline, is also having to show them and educate them on why this is important in spending your time. We're going to take you away from the bedside or doing your job, or maybe taking away from, a little bit and putting on your coworkers to look after your patients or to do something. But it is important because it's going to pay off in the long run. But in the short term, that little bit of change, or that space, I guess, is important. And it really is, it's hard. I don't have a perfect solution. I'll take any suggestions from that. But it is just that part of, we're so used to doing things in the moment of that pre-planning. And I think it is something we have to get better with. And we do that in lots of ways. We're starting up committees, we're starting to ask questions, seeing who has capacity, finding champions to do things and giving them encouragement, who has an interest, using that piece of it and trying to get the staff in to cover them, to allow them to do those things. So it's a thing we're constantly doing, but we're at a much different place than we were, is my part of my perspective.
If I may, and you've now heard me say it twice, and I'll say it for the third time, but maybe with a slightly different slant, the importance of starting with the problem. And which also brings us to the point of emerging innovation ideas from the grassroots, right? Like a lot of the times, especially when organizations are first foraying into innovation, it could be a bit of a top-down approach, where it's something that sort of, for lack of a better word, falls on people's heads. And that's very much a way to create a feeling where, well, now on top of everything else I've got to do, which for everyone in healthcare is a lot, now I got to do this extra thing while I'm struggling to figure out what does it even do for me. Whereas when we flip it around, when we generate the problem statement from the grassroots involving clinicians and patients, off the cuff, we're solving around something that matters. And then when you layer into that the ability to, bringing clinical champions, bringing tools, bringing resources, now we're in the business of involving it, kind of bringing down those barriers and creating enablers to involving frontline staff in co-design, which not only helps them solve a problem, but opens their minds to different methodologies, different ways of working, talking to stakeholders that they normally wouldn't be talking to, rethinking how they do things, sort of all in one. And suddenly you go from this very difficult place to a place where you're actually enabling a culture of innovation. There's a very technical question about the solution itself. To understand this AI tool being implemented, can you provide a specific staff example when they would use this tool to facilitate the discharge process? Do you put in patient factors in this algorithm? So I think this is Hayal Elliott kind of question. Jenna?
No,
I can speak to the workflow that was designed.
Sure.
And maybe Jenna can also speak to it, but the idea was that if you could know 72 hours in advance who is going to become medically stable, then I think like the process that we designed is that a charge nurse would review that prediction. They might then go and speak to the physician about that patient to say, and yeah, just to verify, like, does this seem like a patient that might be discharge ready in 72 hours? And if it sounds like yes, then bringing that insight to rounds to then discuss with the interprofessional team to say, if this patient could be discharged in 72 hours, what are the barriers that we need to take care of today so that when 72 hours comes and they are stable, everything is set up for them. And so what was challenging about the algorithm is that the factors that went into the prediction were very clinical. There were no social factors, and we didn't also have functional data elements that were available to us. And since then, we have been emphasizing with all of our hospital partners that the data that we actually need is clinical notes. And the clinical notes kind of contains all of those social factors, all of the functional elements that are that trifecta of medical, functional, social that is actually needed to predict who is going to be discharge ready. Because if you maybe can predict that they will be functionally stable and they will be medically stable, then let's all focus on the social piece. So I hope that answers.
Yes, thank you, Sheena. Thank you so much. So we're at time, maybe just quickly to Abriel's question around advocacy 2H. Absolutely, Abriel. Let me just say in recap, what this conversation reminds us of. It reminds us that success of AI in healthcare does not rest on the brilliance of the technology. It depends on the system's ability to engage with it in a thoughtful, structured, and strategic way. At WRHN, this early collaboration helped illuminate a core truth. We did not yet have the structures or language or shared understanding to support the responsible adoption of AI in ways that were clinically meaningful and operationally feasible. That realization set in motion the work we're now leading through CareNext, a disciplined organization-wide effort to assess and build AI readiness. So not in theory, but in practice through real-time coordination across teams and portfolios. This includes surfacing issues around data and infrastructure, interoperability, accountability, and clinical integration, but it also includes people and culture. How do we support staff to engage with AI confidently and ethically? How do we strengthen collaboration across domains that don't speak the same language very often? To do that well, CareNext is bringing dedicated capacity to support this transformation, which includes innovation managers, UX researchers, systems engineers, evaluation specialists, and partnership leads who work directly with teams to translate innovation into implementation. So starting in August, CareNext team will provide structure, tools, and co-development support to help teams move from idea to impact in ways that are clinically grounded and operationally viable. This isn't about preparing one project, it's about preparing the system, building capacity, not dependency. And it's happening now through shared ownership, clear structure, and a commitment to thoughtful, real-world delivery. That's what CareNext exists to support, not just the spark of innovation, but the long-term scaffolding to embed it responsibly, equitably, and at scale. With that, I want to thank our panelists for their insights and generous contribution and courage in sharing their experience. I also want to thank Manulife for enabling this important conversation, and to each of you for being part of this collective learning effort. Please visit the CareNext Collective page to watch past sessions and stay connected with what's coming next. Thank you all very much.